Hello everyone, and welcome to another TFC webinar as part of our ongoing webinar series. Thank you guys so much for joining us today. It looks like we've got quite a few of you on here. I'm not going to be hosting today. Obviously, I'm the producer of Texas Fertility Center. My name is Brandy Thomas, and I do not know enough about this topic to host a webinar on this, but I do have one of our wonderful doctors, Dr. Tony Propst, who will be coming on today to discuss tubal litigation and IVF. And he'll be able to share so much information on that, and we hope you guys find this very valuable. Before I go ahead and bring him on, I did want to share a little bit about what we're going to be doing with this webinar specifically, as well as what this webinar is part of. This is an ongoing webinar series. We're doing these on a bi-weekly basis. So we have one coming up in 2 weeks that is on treatment options for endometriosis. We also have one after that is on, it's going to be on information about egg freezing. So tomorrow we're going to be sending out an email to each of you with information about both of those, as well as links to sign up. Now, if you want to learn more about even more webinars that we have coming on, just go to txfertility.com, and there's a section right on our homepage that says events, where you can view all of our webinars and see the landing pages and learn more and register for them right on our website. So that's going to be great. A little bit about how this webinar is going to work. First of all, we're going to be trying something new with this one that we haven't done with our past two ones. Dr. Propst is going to be sharing some slides throughout the webinar, and this is a functionality we've never tried before, and so we're hoping it works okay, but in case that we experience any technical glitches, please just bear with us. We're going to work through it together. And if it ends up becoming too much, then we'll just nix the slides altogether. But we appreciate you guys' patience if we do experience anything. In addition, you will have the opportunity to ask Dr. Propst some questions in the middle of the webinar as well as at the end. There should be a little questions tab on the side where you can submit. All questions that you submit are completely private. None of your information is shared with the other audience members, so you don't have to worry about that. Though we would recommend trying to keep your questions as general as possible so that the answers that Dr. Propst provides can apply to the entire audience. In addition, the past two webinars that we've done, we have gotten a flood of questions for both of them, and that's been wonderful. We're so excited that you guys are so enthusiastic about learning more about this. However, for the sake of time, we will not have time probably to get to all of them. So we apologize in advance if we can't get to your question, but we'll try to get through as many as we possibly can. And with that, I think that about covers it. So I'm going to go ahead and bring on Dr. Propst. He's going to be covering everything about tubal litigation and IVF. And once again, we appreciate you guys joining us today. And this is Dr. Tony Propst.
Good evening, everyone. Thank you for tuning in for this webinar. It's specifically designed for patients who've had tubal ligation or tubal sterilization to review their fertility treatment options. I'm a reproductive endocrinologist at Texas Fertility Center in Austin, Texas, and also see patients in Round Rock, Texas. A reproductive endocrinologist is a doctor who has specialized or done a residency in obstetrics and gynecology, and has done additional specialty training in reproductive endocrinology and infertility. And so it's during this training that we learn surgical techniques as well as fertility treatments, including in vitro fertilization. And that's what I'm going to be talking about tonight, the two treatments we have for patients who've had a tubal ligation, and that would be either a tubal reversal, medically called a tubal anastomosis, or in vitro fertilization. And I'll start by reviewing what a tubal reversal is, the process. Then we'll answer some questions. And after that, we'll go through what an in vitro fertilization cycle and embryo transfer is. Again, after that, answer some questions. So, Brandy, can you show the first slide, please, tubal ligation?
Absolutely. Let me go ahead and share this. Hold on just one second, guys. Okay. Oh, sorry, guys. There we go. All right. Does everyone see it? You can see it?
Yes.
Okay.
Great. So this is a sort of a diagram sort of showing the female anatomy. You can see there's the uterus in the middle with the fallopian tubes to the left and right next to the ovaries. And the tubal sterilization or tubal ligation is a procedure generally where the tube is interrupted in the middle part of the fallopian tube. And there's a bunch of different ways of doing this. One way is you can put a clip on it. Another is you can put a ring on it. A third is you can use electricity to burn the fallopian tube. Oftentimes people have this surgery done at the time of a cesarean delivery, in which case after the baby has been born and the uterus has been closed, then the tubal ligation is done. And generally they'll do a procedure where they bring up a loop of the tube, as you can sort of see over on the left, they'll tie the tube and then separate the portions. So after tubal is done, the proximal end, the one end closest to the uterus, is blocked, and then the distal end, the end closest to the ovary, is also blocked. And so to do a tubal reversal, you actually need to be able to remove those blocked ends and then put the tubes back together. And the way you do that is with very fine suture. Can you go up to the next slide, please? Thank you. You can sort of see in this picture or drawing where now the ligated fallopian tubes have been removed, and the opening, bringing the tube, open portions of the tube together, and then you use some very fine suture to bring those together. And then you test the fallopian tube to see if it's open. Can we go back to live, please?
Yes, sorry.
All right. So there's several different techniques of doing this. The initial one was a laparotomy. A laparotomy is just an abdominal incision, similar to like a C-section incision, where an incision is made all the way into the pelvic cavity, and then the uterus is delivered through that incision, and then typically using a microscope in order to enhance your visualization, or loops that magnify your visualization. Then you can go in, remove the ligated portions of the fallopian tube, and sew them together with very, very fine suture. And then you test it, and then we see that it's open. You put the uterus and fallopian tubes back in and close the incision. And that is a technique that a lot of doctors use. There is and I've been doing that since I was a resident in the 90s. Done many cases that way. Starting around 2010, though, I started transitioning more to a laparoscopic approach. Laparoscopy is a minimally invasive surgery, meaning you have much smaller incisions, and then you put tubes through those incisions into the abdomen in order to get access to the pelvis. And then you can use instruments to remove those ligated portions, and then needle drivers and other instruments to sew the fallopian tubes back together. Can you show the picture on the Da Vinci laparoscopic surgical system, please? Okay, so you can see in this slide on the left is a picture of these the laparoscopic sites, those incisions that are made. So one is in the belly button, through which you put a camera, and then to the left and right of that are tubes where you put the instruments to remove the ligated portions of the fallopian tube, and then sew the tubes back together. And in the upper red portion is the accessory port for my assistant to bring in instruments, or such as the suture I need to put the tubes back together. So these are all small incisions. They're less than half an inch. They close very easily. And it's a pretty cool device. The Da Vinci is actually a robot-assisted laparoscopic. So after all the instruments are put in and the robot is connected, I actually leave the surgery site and I go sit down, as the picture here of the doctor sitting at the robotic console, and actually use the robotic instruments to put the fallopian tubes back together. And the reason this works so nicely is because the robot has huge degrees of freedom, so it enables you to use these instruments almost like they're your hands. And it's nice in that the recovery is quicker with this procedure because there's no large incisions. It does not require a overnight hospital stay. Most patients can go home several hours after the surgery, and they generally need less pain medications to recover from that. So that's my preferred method. Although if you're looking at other clinics, you'll find that many doctors still prefer to do the traditional laparotomy. What you'll find, I think, now is that there's not every infertility specialist does tubal reversal. A lot of them prefer to do in vitro fertilization. For some people, that's their preference. For other people, it's because they either weren't trained in how to do a tubal reversal, or they've done so few they don't feel comfortable doing them anymore. So depending on who your doctor is and what clinic you see, you may get different advice as to your fertility treatment following a tubal ligation. You can go back to live, please. So who is a good patient, for a tubal reversal? Which patients are going to have the most success? Generally, the younger you are, the higher your success rate, and that's true for natural fertility as well as in vitro fertilization. Women are most fertile when they're less than 35 years of age. After age 40, both naturally and with fertility treatments, success rates drop. And after, say, 45, the chances of conceiving, with tubal surgery, naturally or IVF, are very, very, very low. And so generally, women who are younger have higher success rates. Women who have more fallopian tube left after the tubal ligation also do better. If at the time of your tubal ligation, most of the fallopian tube was removed or destroyed, there's not a lot left to work with, and so success rates are going to be less. Women who've had the end of the fallopian tube removed, called a fimbriectomy, and some people are doing that more and more now because there's some suggestion that it reduces the lifetime risk of ovarian cancer. If the distal end of the fallopian tube is removed, then you can't do a reversal because you need that distal end of the fallopian tube in order to pick up the egg so that fertilization can occur within the fallopian tube. And so those are things. Other things, fertility factors. So, most women who've had a tubal ligation were previously fertile, but some women, their fertility may have changed. Maybe they've stopped ovulating. So if you don't ovulate, then even if we put the tubes back together, you're not going to conceive. Some women have partners who have a low sperm count. And so when you have a low sperm count, the chance of naturally conceiving or conceiving after tubal ligation are going to be lower. It could, because that's we call male factor infertility. So it's going to be important for us to check the male partner's semen analysis, because if the count is low, IVF is going to be a better treatment, because in a laboratory you don't need as many sperm to fertilize an egg. Naturally in the body, it generally requires about 10 million total motile sperm in order to have reasonable fertility rates. What about the success rates for tubal reversal? Like I said, in general, women who are younger tend to have higher success rates. And when we look at success rates and report them, they're generally reported in a 2-year span. So this is an important difference between tubal reversal and IVF, is that generally it takes longer to get pregnant after a tubal reversal surgery, because you're putting the tubes back together, but then you still have you're not going to be fertile every single month. And if you look at natural conceptions, it probably is best at 20%, and oftentimes women are older and it's less. So if you look at the cumulative success rate of getting a pregnancy, it's about 70% for women who are less than 37, but it decreases after that. And for women who are greater than 40, it's probably closer to 15 to 20%, which are very much in line with overall IVF success rates. So the overall success rate between the two treatments is pretty similar. But for patients who have a tubal reversal, those success rates are over a 2-year period. So it can take some time. Now, I do have patients who can see very quickly after a tubal reversal, but I also have patients who will come back, 1 to 2 years afterwards who are now pregnant for the first time. With IVF, it's much quicker because you're doing a retrieval and putting an embryo in, so you have a chance of getting pregnant almost immediately with the treatment. What is the cost of a tubal reversal surgery? It's a wide range. In general, the average cost I've seen in my internet research is about $8,500. It tends to be lower at some centers that focus just on doing tubal reversals, and that's all they do. But it can range as high as $15,000, depending on the center you're at. I've seen some costs as low as $3,500 in Mexico, and I've seen a few patients who've had surgeries done there. Usually, I don't see them if it was successful. I'm only seeing them when it was unsuccessful and they needed to do something like in vitro. So again, a wide range of costs. At Texas Fertility Center, it's $11,500 for a robotic tubal reversal. And that cost is based on what the cost of the surgery or the hospital surgery is. It includes anesthesia as well as post-operative stay if needed. So at this point, why don't we stop and let's take some questions.
Yep, so Dr. Propst, just go to the questions on the side panel. Yep, and you can pick which one you'd like to answer.
Yeah, one of the questions is what pregnancies after tubal reversal. So one of the risks of a tubal reversal is that after the surgery, the fallopian tube, now you've had two operations on it, it may not work as well as when you didn't have surgery on it. And so sometimes the opening where you put them together can be narrowed. Sometimes you have a bigger opening on one end of the fallopian tube and a smaller one on the other. And so that increases the risk for an ectopic pregnancy. An ectopic pregnancy is a pregnancy that's outside of the uterus. The most common location for an ectopic pregnancy is in the fallopian tube. And the risk of an ectopic pregnancy is much higher following a tubal reversal. So one thing I see is people who are getting pregnant, getting positive pregnancy tests after tubal reversal, but they are not getting a pregnancy into the uterus. And so in that situation, you don't know of, is it an ectopic pregnancy? Is it a chemical pregnancy? And when I see patients who have repeated early pregnancies like that failing, it usually indicates to me that while the fallopian tube is open, getting pregnant, the embryo is not getting to the uterus. And so ectopic pregnancy is one of the main concerns. What is cheaper, IVF or tubal reversal? In general, tubal reversal surgery is less expensive. The cost for IVF averages $15,000 to $20,000 if you include the cost of medications, the cost of additional testing like genetic testing for the chromosomes. So in general, a tubal reversal surgery is going to be less expensive than IVF. But that doesn't necessarily mean that tubal reversal is better for individual circumstances. It may be that IVF is the best treatment for individual persons. So you have to individualize each case in determining, what procedure is going to give you your best chance of having a baby. If you have had multiple miscarriages, say, assuming those are into the uterus, following a tubal reversal surgery, would IVF be a better treatment in that situation? I would say yes, because it can exclude, you can actually do genetic testing of the embryos with IVF that you can't do in getting pregnant after a tubal reversal. So in that situation, getting pregnant with IVF could reduce your risk for having another miscarriage. I think I mentioned the cost on cost. Again, average cost is probably $8,500 nationwide. The cost at Texas Facility Center for the robotic tubal reversal is $11,500, and that's a cumulative cost. So if you had a tubal with a band or a clip, that's probably has the highest success rate for removing after having a tubal reversal, because it destroys the least amount of tube. Again, the success rate of pregnancy after a tubal reversal varies primarily based on patient age. It's about 70% for women who are less than 37. Again, that's over a 2-year period, and it's probably half of that for women over the 38 and older. Again, over a 2-year period. This works best for patients who really have who block tubes because of a tubal ligation. For women who have blocked tubes because of say infection or disease or other things, this success rate is not near as high, because oftentimes the fallopian tube is damaged, not just obstructed. All right. All right, very good. All right, so I'm going to go back to discussing now in vitro fertilization. So you can have an idea of the difference between the two types of treatment. So in vitro fertilization is a process where a woman takes medications to stimulate her ovaries to produce multiple eggs. Those eggs are then removed under anesthesia in a surgery center, and the eggs are fertilized in a laboratory to make an embryo. The term in vitro refers to outside the body. That's how it got its name, in vitro or outside the body fertilization. We then grow the embryos to a certain stage where they can be either transferred to produce a pregnancy or frozen to be used at a later time. Additionally, you can test the embryo by removing a few cells from it and doing genetic testing to measure the number of chromosomes, and then freeze that. And then once you get the results back, you can then use that information to determine which embryo you want to transfer. And that could be primarily because the embryo is normal, or has a normal set of chromosomes, or if people have specific gender preferences, if they would have both genders. The process takes about 10 to 12 days, and it does involve multiple shots of medications that are subcutaneous or under the skin injections in order to stimulate the ovaries to produce multiple eggs, because IVF is more successful the more eggs that we have. And we'll see a range anywhere from 2 eggs to 50 eggs, depending on the patient. Again, women who are younger tend to, in generally, produce more eggs, and those eggs, in generally, tend to have higher potential to make babies because the egg itself tends to have more normal chromosomes. So age is the #1 determinant of IVF success. Women who are less than 35 have the highest success rates. Women who are over 40 have the lowest success rates. Can we show the first slide as far as the medications, please? All right, you can sort of see this is a picture of somebody who's taken of all the medications they have received. And so unlike a tubal reversal, which is a relatively natural process, and a lot of people are interested in that because they want to try and conceive naturally with intercourse and not have to do fertility treatment. IVF is not natural. It does involve taking injections to stimulate your eggs. It also involves taking medications to support the pregnancy, including estrogen and progesterone afterwards. So, these aren't difficult medications to administer. Patients get very used to doing it. But I know it's speaking to thousands of patients that some patients have some trepidation about doing injections or using the medications. Can you show the next slide, please, the IVF egg retrieval? So once the follicles have reached a certain size, and the way we know this is we do ultrasounds about every 3 days to measure the follicle size within the ovaries. So once the follicles reach a certain size, then we give a shot to mature the eggs, and then we schedule the egg retrieval. And that is done, again, under anesthesia in a surgery center. It usually takes about 20 minutes. And so what we do is we place an ultrasound in the vagina, and that ultrasound goes right next to the ovary. And then we have a guide through which we pass a needle. And that needle will go through the vagina into the ovary, and then we'll drain each follicle to get an egg from it. Can you show us the next slide, please? So this is an example of embryo development with in vitro fertilization. On the top left, we see a fertilized embryo. You can see that it has 2 nucleuses. Again, that's one from the egg and one from the sperm. And in the next to the next top to the middle top, we see a 2-cell embryo. So that sperm and egg have now joined, and now they're starting to make new cells. And so it's divided into 2 cells, and then 4 cells, and then 8 cells. And again, that is what an embryo looks like about the 3rd day after fertilization. It then starts to become a mass of cells, and in the last picture over on the bottom right, we see a blastocyst. A blastocyst is it looks a little bit different because it's got a fluid-filled cavity as well as an inner cell mass. So that's the stage of an embryo that gets to before it implants. And so most of the time when we're doing an embryo transfer, we are transferring a blastocyst or a blastocyst that was frozen and then thawed to transfer again. And you go to the next slide, please. So this is an example of an embryo transfer. The way we do this is we are going through the cervix and putting the embryo into the uterus. So here we bypass the fallopian tubes entirely. So we used a needle to remove the eggs. We made the embryos in a laboratory, and now we're going through the cervix to put the embryo into the uterus. And so you can do this completely with blocked tubes. So you take a catheter, you pass it in, and then you release the embryo into the uterus, and then you check a pregnancy test 9 days later. I think our last slide is the next one, please, Brandy. You can see what this looks like from a ultrasound. So the black area is what we call a full bladder. The reason we do this is so we can look through the ultrasound so we can see where the catheter is at when we're placing the embryo. Again, the goal is to get the embryo into the uterus and the endometrial lining sort of at its thickest point. All right, so we can go back to live, please. So, IVF works particularly well for patients who have additional fertility issues, say like a low sperm count, as I mentioned earlier, somebody who doesn't ovulate regularly, maybe somebody who has endometriosis, and where this can affect your chance of success with a tubal reversal. The overall success rate is determined primarily based on patient's age. If we look at our most national success rates available from 2017, Again, if you start an IVF cycle, what are the chances that you have a baby? For women less than 35, it's 55%. 35 to 37, it's 40%. 38 to 40, it's 25%. Women 41 to 42, it's about 12%. And greater than 42, it's 4%. So you can see with success rates at this level, sometimes women need to do multiple cycles in order to achieve a pregnancy. And some women will do multiple cycles of IVF and then unfortunately not conceive or have a baby. When we do IVF, if we're transferring more than one embryo, it increases the risk for multiples. So the risk of having twins or more is higher with IVF than it would be with a tubal reversal. The thing about IVF is if you want just one child and you're successful with IVF, you don't need to worry about contraception again afterwards. If you have a tubal reversal and the tubes are back together and it works, you're going to be continually fertile, and so you may need to have some form of contraception if you don't want to have more children, or that it could be either a repeat tubal reversal, a vasectomy, or some other form of long-term contraception. Like I said, the cost for IVF in general ranges from $15,000 to $20,000, including medications, and then some of the additional testing like the chromosome testing that many patients prefer to do. So at this point, let's take some questions, hopefully focus more on the IVF. So looks like we don't have any additional questions. We'll just give it another couple minutes to see if somebody has that before we conclude our seminar.
Oh, Dr. Propst, we actually have 3 new questions at the top.
Okay, let me get up there.
Can IVF be done with donor eggs at TFC? So those 3, that one and on, those are all.
Yeah, so we do a semen analysis for the male partner in all circumstances, whether people are interested in IVF or tubal reversal, because we need to make sure what the sperm is, what the sperm count is. And then again, if that sperm count is low, we would recommend in vitro fertilization. What is the maximum number of embryos that we would transfer? I would say it depends on how we're doing it and depends on the patient's age. So we try our best to follow guidelines. So for women who are less than 38, the recommendation is to transfer 1 embryo. For women all the way to age 42, if you've done genetic screening and we know that the embryo is euploid, meaning it has 46 chromosomes, either 46XX girl, 46XY boy, then we'd recommend transferring a single embryo. For women who haven't done genetic testing, women who are older, we may recommend transferring 2 or even 3 embryos. I think 3 is the most I've done recently. Or for some women who we're transferring embryos, but we're not achieving pregnancy, oftentimes we'll then say, well, maybe we should transfer 2 embryos or 3 embryos. So I would say 3 is the maximum that we have done, but over 90% of our patients receive just a single embryo because we're trying to reduce the risk for multiples and the complications with that. IVF success is pretty similar for pretty much all diagnoses except for diminished ovarian reserve. Diminished ovarian reserve is where a woman has fewer eggs than expected for her age. And so when we don't get very many eggs, our success rate for IVF is lower. Women who have PCOS, on the other hand, tend to make lots of eggs. And so they generally tend to have a very good success rate with IVF. And for a woman who has PCOS, who isn't ovulating regularly, then IVF would be the best treatment, because if you did a tubal reversal, you still have to do treatment to try and get them to ovulate. So in that patient, I would recommend going straight to IVF. So success rate of IVF compared to IUI, IVF is a higher success rate. when we do IUI or insemination, intrauterine insemination, oftentimes we're doing that with medications such as Clomid or Femara. These are oral medications, or injections to help stimulate the eggs to develop. But in general, the success rate with those treatments is about 10 to 15% per cycle versus 50% or higher for women who are less than 35 who do in vitro. So IVF is about 3 times as effective as an IUI treatment. Question is what type of medication to stimulate ovaries. Most of the time we're using injections or medications called gonadotropins. These are synthetic versions of the follicle stimulating hormone that your brain produces naturally. And so they are able to produce that in the laboratory. Occasionally we will supplement with things like Clomid, primarily in patients that we're trying to jumpstart the ovaries before we start the injections. So most of the time, the predominant thing we use are injections or gonadotropins, but occasionally we'll supplement with Clomid as well. There are some places that do minimal stim IVF, where they'll just use Clomid, but we typically don't do that at Texas Fertility Center. So at Texas Fertility Center, we have 7 physicians. We have 5 in the Austin area. We have 1 doctor in New Braunfels and 1 doctor in San Antonio. And all 7 of us perform in vitro. We're all board certified reproductive endocrinologists who've done the additional training in vitro fertilization and other fertility treatments. So a specific weight to have the procedure done. For tubal reversal, I don't really have a weight limit, although you know, the complicated, you know, for women who are obese, I would say that the surgery I do, the laparoscopic tubal reversal, is better because you have more surgical complications doing an incision in women who are obese. For IVF, the success rate is best for women who are normal weight. It does decrease a little bit for women who are obese. And there is a BMI cutoff, or body mass index cutoff, of 45 because patients are going through anesthesia in a surgery center that's not in a hospital. And so that is the limit our anesthesiologists are comfortable with. So for women who have a BMI above 45, they would need to lose weight before they could do the IVF process. Okay, well, I think we've answered all of our questions. I appreciate you guys submitting them. I hope that this was helpful. If you would like to make an appointment with me or one of our other physicians at Texas Fertility Center, please go to txfertility.com. You'll find out information on how to schedule a new patient appointment.